You're listening to Medscape's In Discussion series on cancer survivorship, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ann Partridge, Professor of Medicine at Harvard Medical School, Vice Chair of Medical Oncology, Founder and Director of the Program for Young Adults with Breast Cancer, Director of the Adult Cancer Survivorship Program, and Eric P. Weiner, MD, Chair in Breast Cancer Research at the Dana-Farber Cancer Institute. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hi, I'm Dr. Ann Partridge, and I'm a breast medical oncologist at the Dana-Farber Cancer Institute, where I also direct the Adult Survivorship Program. Welcome to Medscape's In Discussion series on cancer survivorship. Today we'll discuss disparities in cancer care and ways to deliver culturally competent care. First, let me introduce you to my guest, Dr. Narjust Florez. Dr. Florez is the Associate Director of the Cancer Care Equity Program and a thoracic medical oncologist at the Dana-Farber Brigham Cancer Center. Dr. Florez's clinical interests include targeted therapy for lung cancer and the care of women with lung cancer, including their unique aspects of cancer survivorship. Apart from her clinical interests in lung cancer, she is also a leading and productive researcher in cancer health disparities, gender and racial discrimination, in medical education and medicine in general. Welcome to In Discussion.
It is my true pleasure to be here with all of you.
So I like to ask each of my guests when we start out a question as a bit of an icebreaker. And I think for you, there are two issues that I'd like to get at. One is what drew you to the cultural competency space? And a related area is why focus on younger women with lung cancer? So maybe start with the cultural competency issue, and then we'll move into the why younger women with lung cancer. And I suspect they're related.
The matter of cultural competency is a personal matter. My family and I have experienced health disparities as soon as we arrive into the country due to language barriers and insurance issues. And I continue to see those struggles that many immigrant families of underserved populations face during cancer care during all phases of my training. Along those lines, my focus in younger women started in fellowship. I noticed that they are understudied group and they have their own set of unique disparities, which includes delays in diagnosis. They're often not offered the opportunity to be in clinical trials, and very often many of them face a stigma and do not feel comfortable disclosing their diagnosis of lung cancer with their family and friends. And I actually have patients that have told their families they have breast cancer instead of lung cancer because that tends to be more accepted in the society. And I think that's a large burden for these young women to carry on top of having lung cancer.
Can you talk a little bit about the way that you approach and would advise that we approach patients who may not be just like us or maybe like us and are trying to manage what you just described? You come at it from a place of cultural humility and appreciating cultural differences and perceptions. Do you want to comment on that?
Yes. So cultural humility is a term that was created no long time ago, 1998, after the riots in LA by two social workers. And this is to try to eliminate the power imbalance in medicine. And it has three basic principles. The first principle of cultural humility is my favorite, which is lifelong learning, which is the opposite of stereotyping and unconscious bias. So instead of coming with assumptions about what survivorship looks for some patients, we come from a point of questioning and trying to learn how they see survivorship with their own eyes, because our culture affects how we see cancer survivorship. So lifelong learning. The second principle is to make sure we are trying to fix this power imbalance, the doctor, the patient, the healthcare system, that patients feel comfortable. And the third principle of cultural humility is accountability, not only to institutions, but also to individuals that we try to provide equitable care, all aspects of cancer care for all patients.
That's wonderful. So 3 pearls of wisdom around this. And do you bring that into all of your care of patients yourself? And how do you do that?
I try to. We all have been guilty of microaggressions and our own bias and stereotyping. medicine is largely based in putting patients in categories. That's how we learn in medical school. So practicing cultural humility is literally removing those categories that we have learned for over 10 years of training. So the first thing I ask my patients when it comes to cancer survivorship is how cancer survivorship looks to you. What is important to you? So I practice the first principle of cultural humility because I'm trying to learn. And this is the lifelong learning. Because for some patients, running is part of their survivorship. For other patients, cooking a large meal on Sundays for family after Mass is part of their survivorship. So coming with that mind of trying to learn, I think is what I do when I see each patient. And when I find myself stereotyping, first I apologize and I ask, what is this to you? And we go from there. It also is very good for our patients' relationships.
So they feel like you're really, and that you are really listening and you're trying to get to know who they are. Let me push you on that though. So, I face this in my own clinic in survivors where, at least in breast cancer, and I would imagine in lung cancer too, in America, they're often overweight and they don't exercise. Or you have to get someone, if it's a smoking related cancer, to try and quit smoking. You want to meet them where they are, but you also want them to kind of change, right? You want them to improve their health behaviors. How do you approach that in survivorship in a culturally competent way? So if your idea of having a good time is having a big meal on Sundays, how do you help them to say, okay, have the big meal on Sundays, and at the same time, can you fit a little running in, quit the smoking? And how do you manage that? Because we are trying to modify behaviors.
So I often offer recommendations that are goal-oriented. So I'm going to tell you a very recent patient. Her goal is to see her granddaughter graduate from high school. She has raised her granddaughter. So that's her goal. How can we get there? In order to get there, we have to do these behaviors so you can get to that main goal. And I often tell them to visualize because that really helps them. So I'm trying to actually ask this patient to walk. We need to walk before surgery. We need to get there. So I asked her to visualize that granddaughter's graduation in high school. And it has been motivational for her. So she has one goal. And we also have certain times. If you say you need to walk, that's not very specific. So I try to provide instructions in their lifestyle, right? Because she has to pick up the granddaughter from school. And that's what her life revolves around. So we're like, we're going to walk 15 minutes during this time to this time. And I also accountability, which is also in cultural humility. So when they come back, I'm like, all right, how many times did we walk our 15 minutes? And it has to be realistic goals because these 150 minutes that we want patients to do every week may not be possible for a patient that had a recent pneumonectomy. So goals that are realistic, very set up encounters in which you can follow up to see if the goals were achieved. But it can be challenging, particularly with smoking cessation.
You must be an amazing doctor trying to really understand each person. And do you write it down in your notes in terms of, here's the goal I set with Mrs. Jones?
Yes, because it's a very good reminder. And I also write things that are important for my patients. So I have a patient that her dog is her life. So I write the name of the dog every note so I remember. So we see our patients more than just their cancer because that's what all of them want. So they're not only the lung cancer patient, they're a patient with lung cancer that has a dog that we're trying to get her to quit smoking who has a granddaughter. So that provides a more holistic approach. We don't see them only as their disease, but as the human they are.
So, taking that a little further, so you do what you can in your clinic to support these patients. But we all know that particularly underserved minority communities, people coming from other countries, different groups face access to care issues, especially after all treatment has been completed. From your vantage, what do you do to help these folks with resources or to try and increase access for those people to get what they need in their survivorship?
That's certainly true. When patients are in active treatment, it's all hands on deck. Everybody helps, the neighbors help, everybody helps. When treatment is completed, patients are left on their own and they face a different type of challenge, which is the very strict follow-up that we have, the need for CT scans, the need for seeing the doctor, and they don't have the same level of support. Something that we are, implemented at Dana-Farber that helps with survivorship is patient navigation. And we have navigators that are disease-specific because their needs will vary also by the type of disease. The cervical cancer needs may be different than a patient with lung cancer. So patient navigation help them understand this very complex healthcare system and also provides an additional follow-up besides just the doctor's visits. That has been successful in many studies across the nation. And in Dana-Farber, we have implemented that for several disease-specific navigation and also neighborhood-specific because social determinants of health affect your survivorship. So when we ask a patient to go for a walk for 15 minutes, if she doesn't feel safe in her neighborhood, how is she going to go for the walk? So providing that and providing resources, many patients are not aware of this. So we are creating a list of resources, foundations that may provide grants, hair prostheses or wigs that they can be obtained at a lower price. So we provide resources and navigation will be very helpful. It is very helpful to these patients after all treatment is completed.
So patient navigation programs are really, I think, a key to helping our patients when they're in this brave new world of cancer, which is usually very new for any person. Some people have had some family or friend experience. And especially in folks who may not be able to work the system, that's something that we need to reach out for. And if you have it at your center, that's fantastic. If people don't have a patient navigator at their center, how do you recommend people manage those kinds of supports? Are there other supports in communities that people can reach out for or nationally?
Yes. So for lung cancer, there are several patient advocacy groups that are led and created by patients. In lung cancer, they tend to be very mutation specific. So there is the EGFR resistors, there is the ROS wonders, the KRAS kickers that provide that community, usually through social media, because you may not know other person that have lung cancer. So that provides a sense of community. And there are also larger groups than those, including the GoTo Foundation and Longevity, that they have a phone line that can provide, as needed, patient navigation as well. So if the patients do not have patient navigation in the institution, these two large organizations have a phone line that Monday to Friday, patients can call with questions and concerns, and they can receive some guidance. Like insurance can be extremely confusing for patients, as well as, do I get a second opinion or not? And these groups are able to provide that free of charge for patients.
That's great. And I know that even more broadly, a lot of the national organizations have general navigation programs or disease specific, like Susan G. Komen has a breast cancer specific navigation and community program, and Cancer Care, which is based in New York, but a national organization. And I believe the American Cancer Society also have versions where people can get some navigation. And I would imagine they would have a number of languages, although I don't know that specifically. I assume American Cancer Society at a minimum has Spanish.
Yes or no. So the large organizations, the American Cancer Society, may have Spanish resources, but a lot of these advocacy groups are still in English. The GoTo Foundation just completely translated the materials this year, and now the Lung Cancer Registry and the GoTo Foundation is going to be in Spanish too. But there's still a gap there when it comes to language, not only about these phone calls or navigators, but also by educational materials. We did a large study that shows the majority of educational materials in lung cancer are still in English. So I think we are trying to work, we go to, and we're creating this series about myths in cancer for the Hispanic community. So they're very culturally targeted to the myth that my gente tends to have when it comes with cancer and that can delay care, like fear of having chemotherapy, fear of surgery spreading the cancer. So we explore those in Spanish, but there's still a lot of room for improvement when it comes to language inclusion.
All right. Well, we and you, we all need to keep working on that. And most importantly, even if there aren't resources there, just to be aware of these differences and that these fears that people may be bringing to the table, because sometimes if we don't ask, we don't know what might be getting in the way of them optimizing their care, right?
Yes. And I think something that is related to all of this is when we talk about patients, we need to understand their daily practices. when it comes to survivorship. And I use the example of a recent patient that I sent to nutrition, and she came back to me and say, I'm not going to follow that diet. I never had eaten squash in my life. This diet has 0 tortillas, 0 beans, no rice. That is the main backbone of my diet. So have recommendations that are based on what our patients eat and what our patients do. And also that are realistic, because groceries are extremely expensive. And some patients may live in a food desert. So if we are providing diets like fresh salmon with kale, I can tell you my older patient who's Latina, she will not eat that. So recommendations and support that are tailored to the practices that are realistic.
No, that's great. And I think that's a perfect segue into another thing I really want to bring up with you, which is the financial toxicity. And not that all things cultural and biased are also associated with finances, but there's a lot of kind of confounding of our health outcomes that we see by the socioeconomics beyond the racial ethnic disparities that we see. So how do we as clinicians managing cancer patients and survivors, what can we do to support our patients with regard to the financial toxicities that they face, often from wherever they come from?
Yes, you are correct. And so 80% of our patients' outcomes are associated with social determinants of health and 20% with clinical care. So your patient can have all the mutation you want, but that 80% is still have a higher burden and effects on the healthcare. Transportation and access to care are related to finances. So one of the things is that we haven't received training about financial toxicity during fellowship or residency. It's often a subject that, people don't talk about it, but it's a reality. Cancer care is one of the top reasons why people file for VAT vacancy in the United States. So one of the things that I have in my note in Effec, because the healthcare system is always running and we're always running, I have a smart phrase and know my notes to ask about financial toxicity, because the first step is to ask. Patients will feel ashamed the majority of the time to share that with their doctors, so that we keep it to themselves. So what I ask anybody who's listening to this podcast, the first thing you can do is to ask. And I ask easily, what is your copay for your cancer drugs? How are you getting your cancer drugs? That's a way to get there. How are you getting back and forth to appointments? And do you have enough food at home? Those are some ways that you can ask and address access to financial services. And another thing is that a lot of patients utilize financial advisors in healthcare. So utilizing the financial offices in our hospitals can be very helpful for patients, because this is all new, particularly to younger patients in which a cancer diagnosis is disruptive. They don't have life savings, they have children responsibilities, and they need to stay in the workforce to keep their insurance.
So you hone in and ask them about about their care in order to open up that larger conversation around finances. And tell me how that goes. How do people receive that? Are they open to it? How do you do that? Because I think a lot of us might have difficulty with that. So give us some pointers here.
So some patients don't say anything. They say everything is okay, but that just opens the door, because I have noticed that in the following appointment, they bring it up. So you open the door for them to feel comfortable. Some patients do say, oh, my copay is very high, and many of them may not even have been enrolled in the drug assistance program, that our teen or your teen at the hospital can help them enroll in a matter of 15 to 20 minutes, and their copay can go from $900 a month to $20 a month. So that's an action that we can take easily. When it comes for transportation, the American Cancer Society has support for transportation, and also some of these apps or ride shares are providing extra support for patients with cancer. But patients don't know about those resources. So I think opening the door and connecting them with the right resources, I think is a very solid step when it comes to addressing financial toxicity.
That's great. And I think we should add it to our essential review of systems, the targeted review of systems, especially when you're talking about starting people on expensive things, or if you're having them come frequently for visits, or you're seeing any signs of no-showing, right? It may not be that they don't want to come. It may be that they just can't get there. It's very helpful. So in our last couple minutes, I just want to touch on one issue, and that's our own biases and what we bring to the table. How can you tell us to manage that? As you said, we all have biases. We have to recognize them, but how do we manage that in our day-to-day when caring for people?
The first thing is what you just said, and recognizing that we all have biases and self-reflection. If you're conscious of your biases, you will be more careful. So I have bias and I come clean because, the bias researcher probably doesn't have them. Yes, I do. So self-reflection is the first step. And after that, I think is realizing how the interactions go with our patients and how we refer to our patients. I think that is also a very good test. I often go back to my notes and read my notes to make sure that my thought process is also no bias, right? Because we often just dictate notes that can perpetuate stereotypes in patients. A lot of my patients often are labeled as anxious, and then everybody stereotypes that patient as an anxious patient. But if you're 30 years old and you have a 5-centimeter tumor in your lung, I will be anxious too. So self-reflection, going back and reviewing interactions in your notes. And also, the more you diversify your experiences, the better your biases get. Diversifying experiences mean practicing the first principle of cultural humility, which is lifelong learning. And that will help us. But the number one thing is knowing you have them and try to mitigate them.
Fantastic. And Jay, I've really enjoyed this conversation. So today we've talked with Dr. Narjust Florez about cultural competency, lifelong learning, staying humble, having humility, and really meeting your patients where they are at diagnosis and through survivorship to optimize their care, whoever they are. Thank you for tuning in. If you haven't done so already, take a moment to download the Medscape mobile app to listen and subscribe to this podcast series on cancer survivorship. This is Dr. Ann Partridge for In Discussion.
Thanks for listening to Medscape's In Discussion Cancer Survivorship podcast series with our host, Dr. Ann Partridge. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on cancer survivorship.